Hello, this is your brain on drugs, and this is the punk rock psychiatrist. All right, so continuing on with the ADHD series. Last time we started talking about how to treat ADHD, and I started with the stage zero non-pharmacological, non-pharmaceutical treatments, diet, exercise, lifestyle, therapies, coaching strategies, all that stuff, and you want to use those first, and if they don't work, you're going to move on to medications, but they may give you some benefits so that you don't need as much medication. And we're getting close to talking about medications, and so kind of as an intro, we're going to talk about some aspects about the meds to help you pick them. All right, so I'm going to talk about like all the different things that you want to consider, and then let's see, I believe next time I'm going to start talking about stimulants. Yep. The next ADHD episode after this one, I'm going to get into stimulants. We're going to talk about the history of them. We're going to go through them one by one. We're going to talk about all the different formulations and what makes them different and all those details. But today, I'm going to kind of give you an overview of what all those aspects to consider are. All right. So, what are some of those topics we're going to talk about today? First, we're going to talk about choosing a medication. So, some factors that go into picking which one. We're going to talk about dosing. There's different ways to dose these. The duration of action. There's different durations of action. We'll talk about like how to make those considerations, and then there's like tons of different formulations, and we'll talk about kind of factors to consider when you're going to pick which formulation. And like I said, next time we'll actually start getting into what those formulations are so you can see information, how you can use today's information when you're trying to pick which med that you want. All right. So, first, choosing a med. All right. Well, we're talking about stimulants first, and there are two. It's pretty simple, right? You've got your amphetamines and you've got your methylphenidates. Now, is it that simple? No. You've got some left and right enantiomers. You've got some mixes of enantiomers. You've got or we're only using one enantiomer versus another one. You know, we've got some differences. We've got different types of amphetamines. So there are some differences here between our amphetamines and methylphenidates, but as a category, we basically have amphetamines and methylphenidates. The only other stimulant that we have is modafinil and armodafinil. Those are not approved for kids at all, and they are off-label for adults, but not used that often. And those round out the stimulants. And after I talk about methylphenidate and amphetamines, we'll talk about the modafinils, and then after that, we'll talk about the non-stimulants. Okay, so as I mentioned in our uh, treatment algorithm last episode on ADHD, stage zero is the non pharmaceutical stuff. Stage one and two is either an amphetamine or a methylphenidate, and the next step is the other one, right? So let's talk about kind of some factors that would go into should I give this person the methylphenidate or should I give them amphetamine? How do I know which one to give them? Right? Does it matter? Do I just kind of randomly choose? Um, One factor you might consider is what's working for other members of the family. I mean, that's always something I think about, especially with psychiatric medication, which is pretty much all I do. I wonder, do other specialties think about this as well? Like when they pick a blood pressure medication, do they think, oh, what did your father take? I don't know if that comes into play, but with psych meds, it definitely does. So how do we know whether we go methylphenidate or amphetamine? What I usually see, and this is just in my personal experience, and remember, I work in a different environment than most folks do out there. Um, and I'm going to describe this a little bit. So, I work in a system where everyone has free healthcare. And so that healthcare is highly regulated, right? So it's like, well, our healthcare system doesn't want to go to the most expensive drug first, but often in the private sector, they will do that kind of thing. I'll get patients that came from the private sector and they're on some drug we don't even carry in our pharmacy. And I'm like, this is the only drug you've ever taken? They just went straight to this, straight to the branded product. Like, I mean, who's getting free lunches from the drug reps? Your doctor, right? Like, you should not go to the expensive drug first. Do not do that. Do not just, there's never a case in psychiatry where I would say go to the drug that has not generic first. There's just no reason for that. Because one, they typically don't work that much better. Um, and to me, they're like third, fourth line. It's like if I try a couple of the standard things and we're not really getting anywhere with it, then I'll, if I think appropriate, use that one. But I see people I remember when Vibrant came out, I was seeing all these patients on Vibrant, and like I was like, we don't even have Vibrant. Our pharmacy doesn't even, in the military, our pharmacy didn't even carry Vibrant. And I was like, why are these people going straight to Vibrant? This thing is like really expensive. Same thing with when Prestige came out. I was like, why are these people being put straight on Prestige? Isn't this like exactly the same thing as like Effexor? But like that's what happened, right? They I don't know, these doctors don't have time, and they basically give people whatever comes to their mind first. Luckily, I have more time to think about things, and I've done a lot of thinking about it, and I'm hopefully saving you some time from doing some thinking. Um, but when I'm, and there are types of amphetamines and methylphenidates that are really expensive because they're newer formulations of them, and then there's the old stuff. I'm going to go with the old stuff first, but like I said, let's go back to this question of which one of the which category do we go with first? I've got some statistics here. Um, what I have here is that I mean, here's the other thing: these meds are really effective. If you remember when we talked about the STAR D trial, we talked about that 67% of people with depression will respond to some sort of depression and respond, not necessarily get completely better, to some sort of antidepressant after like, was it like 4 trials, 5 trials? But this is the good news about ADHD. 88% of people are going to respond to at least one of them. All right. So that means after 2 trials, we've already gotten 88% of people better. And 70 to 75% of people are going to respond to one or the other. That means we have a 70 to 75% chance of getting the med right the first time. And then we raise our odds up to 88% after we try the other one. So this is why I love treating me some ADHD, because people get better, and they get better fast. Now, I know a lot of people probably criticize and say, well, that's because they don't really need it and everyone gets better on these. And, we've already had this discussion, so we've moved past that. Now, I mean, we're talking about here people that have ADHD that need treatment, right? That's who we're talking about. And I like finding these people, and I'm like, oh, wow, someone that's actually going to like have a lot of benefit because I'm going to be able to get them a treatment that helps. Because like, I'm always hoping that like I can give someone a really helpful treatment. And it's like, no, they're going to be tough. They're not an ADHD case. So inside of that, I would say amphetamines have a slightly better response than methylphenidate. And we're going to talk more about that when we talk about the chemistry, but just a little preview. Methylphenidate is a norepinephrine dopamine reuptake inhibitor. And it does it way better than bupropion. So don't think that they're equivalent. And amphetamine does that, and it's also a dopamine releasing agent. I think it might be a norepinephrine releasing agent as well, but I'm not sure. But it also has effects on the VMAT2 receptor, which helps to release more dopamine. So amphetamine basically does more. It increases your levels of the chemicals that will treat you more than methylphenidate will. And so, kind of going back to what I was saying before, what's the algorithm I see in the military? Well, in the outside world, it might be, let's give this guy Mideas, right? Like I've seen this. A patient of mine, he was like straight to Mideas. And I'm like, okay, so this is like a newer branded product. I mean, yeah, I guess it's like a longer acting amphetamine, might be better, but like, might we not try Adderall XR first? No, we did not, or they did not. They went straight to Mideas. And like what I see in the military is first people will try, they might try Strattera or Wellbutrin, bupropion, and then they might try the other one of those. So they might go, they go with the least likely first. So first they go to bupropion, that doesn't work. Then they go to Strattera, that doesn't work. Then they go to methylphenidate, that doesn't work. Then they go to Adderall, um, amphetamines, right? So it's like, okay, it took you 4 steps, 3 steps to get to the normal first line treatment, and then another step to get to the other one. And they basically started with the weakest thing first and just worked their way up. And that's how it works in a system like the military. That's not how I operated. I go straight to the amphetamine for adults. I'm like, that's the most likely to work, and so why would I want to fool around with a bunch of stuff that's less likely to work? I mean, why fool around with bupropion at all? Like, I talked about this last time. We'll talk about it again. There are cases I do it, but like, why am I? What, this is a legit case. I'm not concerned about a bunch of other factors. I want to treat their ADHD. Why am I giving them bupropion? Strattera doesn't work as well, takes longer to work, has more adverse effects. You know, why am I using Strattera when this is a person that should get a stimulant, right? And then I think it's reasonable to give someone methylphenidate before amphetamines, but I just think the amphetamines more likely to work, and so I typically give most of my patients mixed amphetamine salts, otherwise known as Adderall, first. However, for kids, um, which I don't treat, I've treated very few. I would tend to lean towards methylphenidate for kids, especially younger kids, because um, adults just they tend to need higher doses and like stronger stuff to work. Kids don't, and they kids tend to tolerate methylphenidate is easier to tolerate than Adderall. I don't see a lot of tolerance problems in adults, but with kids there is more of a tolerance issue. I'm not saying would not use amphetamines in kids. I'm just saying I would probably use methylphenidate first. There are some issues with that. You know, there if they have difficulty swallowing, there's less options, but we'll talk about a lot of that stuff later. So I do tend to favor amphetamines first for adults, not for everyone, but I tend to. And for it depends. If they tell me that they took Ritalin when they were in high school, and which is methylphenidate, and it worked great for them, I'm probably going to give them the same thing again. I'm like, look, that worked great for you. Why am I going to give you something different? If they said it worked great and then it didn't work and then they ultimately didn't like it, I'll probably be like, oh, let's go with the other one. If they took Adderall before and they hated it, and even if it was like 5-10 years ago, I'm probably going to not give them that again. I'll probably go with the methylphenidate, right? So also, like, say they have a family member that's on methylphenidate and it's working great, I would probably go with that one. So I'm going to use factors like, what's your family taken? What have you taken before? How sensitive are you to medication? How anxious are you about one medication versus another? Do they come in and say, my friend's on this, I feel more comfortable with that, I'd like to try that first, then I'm going to do that. But like, all things being equal, if I have no outside factors that are really pointing me one direction or another, I'm going to give amphetamines to adults and methylphenidate to kids. Okay, that's basically what I'm going to do. If there are some extenuating circumstances, such as the ones I just mentioned, I might go the other way. And I think if you go the other way, there's nothing wrong with that. There's nothing wrong with giving an adult methylphenidate first. It, like I said, it's it's almost as likely to work. And so I could see an argument for that of like, well, let's try the one that's a little bit less intense first, and then go with the one that's a little bit more later. Just, I've treated a lot of people, and in my experience, Adderall works a lot better. And so I tend to want to give the one that works a lot better. All right, here we go. So this is, remember how I said that these work really well? Not only do 88% of people respond to one or the other, but the effect size is huge, right? So the effect size for our antidepressants, it was like 0.3, not very good, right? And if you'll remember, effect size below like point 0.2, I think it's like point 0.2, it's like you don't even notice a clinical difference. And then it's like point 0.2 to point, what is it, like point 0.2 to point 0.5 range, it's like kind of some difference. And then like point 0.5 to like 1 is like moderate. And then like 1 or greater is like a lot of benefit. These have a 1.0. They're the most effective medications in psychiatry. They work fast, they work well. Um, that's where you can run into some risk when you have that sort of thing. But they are the most effective psychiatric medications, 1.0 effect size. Well, not necessarily. Ketamine might be a bit higher um, than ECT, but that's not really a drug. So there are some things out there that are close to this, but this is high, right? For preschool kids, I have point 0.4 to point 0.8, so maybe a little bit less effective. I've even seen effect sizes up to 1.7 if fine tuned appropriately. So that means we've got them on the right drug at the right dose and the right formulation, the right timing. Everything is just completely fine tuned to the max. And the cool thing about these drugs are you can fine tune the hell out of them. That you can, there is so much you can do with these meds that you can't do with any other psychiatric meds. And it makes them really fun to prescribe because if the patient's having like a slight issue with something, you can make very fine adjustments by changing the med, the timing, the combination of meds, etc., to maximize that benefit. And so, yeah, you can fine tune that up to 1.7, and then also don't forget placebos in there. And we don't talk about placebo when we talk about effect sizes of drugs. So when you include that placebo, that effect size is even higher, right? And I would guess, I can't say for sure, that the placebo effect for these meds is probably stronger than almost anything else just because of the reputation they have, right? If something works faster, it's more likely to work, and you've heard really good things about it, it's probably going to have a stronger placebo effect. So, and remember, these effect sizes are discounting placebo because this is in the trials they tested against placebo, and it's like the difference between how well the drug works and the placebo works is how they determine the effect size. All right. So now we've picked one of the two meds. There's lots of different formulations. In adults, normally I'm going to go Concerta or Adderall XR. If I'm going to go methylphenidate, none of the other methylphenidates, for the most part, are useful in adults. They just don't last long enough. Adults need longer lasting meds. I'm not going to start a kid on Concerta. Um, I think it's going to last way too long. I'm going to start with much shorter acting stuff with a kid. With adults, pretty much even Concerta may not be long enough for an adult. Even Adderall XR, I often have to add a short acting after the extended release, and we'll talk about that later. But like adults, they're bigger. Um, they just tend to eat through the meds faster. So I go ahead and start them on the longest acting stuff. And now my Deus is longer acting than Adderall XR, but like I'm going for the longest acting thing that is like available as like a cheaper generic product. So yeah, I'm gonna go with one of those and then the other. Um, you could give them both. I've heard this. I've never done this. You could say, here, I'm going to give you some Concerta and some Adderall so that you get an opportunity to try them both, right? Because and then you tell me which one you liked better, and we'll go with that one, right? So because the thing is, some people are going to like Concerta better, some people are going to like Adderall better, and say I start them on Adderall and they get better, and it's like, hey, I'm good to go, but we never even got to see if Concerta was going to be even better. They might have less side effects on it. They might find that it lasts a little bit longer for them. They may find that it was a little more effective. So you could consider. I've never done this, but I've heard of doing this, and maybe I should consider doing it. I don't know. I just feel like the pharmacy's going to look at me weird if I give them both at the same time. I mean, but of course I don't have to do it both at the same time. I could say, oh, I know your Adderall worked really well for you, but why don't we try Concerta and see how that goes? And then next time you can tell me if you want to switch back. I don't know. I haven't messed with that, but like you certainly could. That way you find the one that works the best. Um, so if there's an adequate trial of one of those and you've maxed it out, kind of gone to the highest dose, and there's been no improvement or they've had intolerable side effects, go ahead and move on to the other one, right? So that's how I do every med. It's like if you don't tolerate it or we kind of max it out and we're not getting anything from it, let's switch over. And like you may think, well, if Adderall didn't work, Concerta certainly won't. There's no way to know. Even though they both are NDRIs and Concerta doesn't have some of the other properties, that doesn't mean that for whatever reason in this patient, the thing is, there's funky things with each med that we don't even know about. I find out funky things about meds all the time. I'm like, wait, fluoxetine does that? Wait, Celexa does that? I had no idea that it had that other weird effect. I just found out something interesting about, um, I can't remember what med it was, but it was a med that it had some sort of sigma. I know Luvox does, but it was some other med that had some sigma activity. And then there was another med that had like, it was vortioxetine. Vortioxetine has like a lot of anti-inflammatory stuff and weird mechanisms of action of things I had never heard of before. And on my next update episode, I'm going to go into detail on that. But I was just like, who knew vortioxetine? I thought you were just like not that interesting of a med, but oh, you've got some interesting effects here that I don't know of any other med that does this. And and the thing is, that's the kind of thing. Just because their primary mechanism of action seems like it's the same, there's tiny subtle differences, some of which we know, and some of which we probably don't even know what they are, that would account for why it works for one patient but not another patient. All right. So moving on. Um, so if you've tried both of those, you could also consider a switch to another drug within that class, right? You could try a different amphetamine. You could try a different methylphenidate, right? We've got Focalin, which is the right enantiomer of methylphenidate. So it's like R methylphenidate. And then you could try Dexedrine, which is R amphetamine. And I don't think they make Dexedrine anymore, but they've got Procentra, they've got Zenzetti. So there's some substitutes for that. Vyvanse, which is Liz dexamphetamine. So it's basically R amphetamine, but it's got the lysine group on there. We're going to talk about the differences of all these meds later, but there are some subtle differences. And so just because they don't necessarily do well with one of either Concerta or Adderall, you could consider some sister compounds, right? Um, if a patient's behavior worsens, like they're more activated, you may consider that they don't have ADHD. Perhaps this is anxiety. Perhaps there's another diagnosis here. You thought it was ADHD, but you were wrong. Um, a lot of people present with ADHD symptoms, but they actually have something else. It could be bipolar. We talked about the differential already. Go back to that. I think that was the first episode on ADHD I did. So you always be prepared to scratch your plan and start from scratch and be like, you know what? Maybe this drug isn't working because they don't have ADHD. All right. So consider that. And then if you've got folks that can't take stimulants for whatever reason, they don't tolerate them, they have a history of abusing them in the past, whatever, consider non-stimulants. Maybe it causes some sort of side effect that they don't tolerate. Maybe it's like really having an effect on their blood pressure. Consider a non-stimulant. All right. Let's move in. So that was choosing a med. And we'll be talking a lot more about choosing meds, but that's kind of like my higher level choosing meds. So let's talk about dosing. How do we dose these? All right, here's the thing. No parameter predicts optimal stimulant dose. So essentially, there's not a good way of knowing what dose is going to work. Their weight, their age, their gender, the intensity of their symptoms on a scale, how high the score is on a Connor scale or whatever. Each person has to have the dose titrated to their individual needs and duration of dose. I can make guesses on what that's going to be, but there's no way we can predict it. Okay. There are, for kids, we do weight based. And even, I mean, like I said there just a second ago, weight can't predict it, but we don't want to give them too high of a dose. And so the schedules that we give kids, You can look up the package inserts for the meds. They will tell you at what weight ranges to start on week 1 and 2. So normally you go week 1 and 2 this dose, and then week 3 and 4 this dose, and you don't even necessarily have to see them back after that. You could have them titrate up the doses themselves, and then you see them back after they've had the opportunity to kind of fine tune their own dose, or you could see them back more frequently. It's going to be patient dependent. It's going to be clinic dependent. That's you run it the way you want to. If you think you need to see them more frequently, see them more frequently. If you think they can titrate on their own, give them a little bit longer. Give them some flexibility with the dosing range. Okay. um, but yeah, with kids, we're normally going to dose, or I'm always going to dose based on weight. And then with adults, um, I take weight, age, gender, severity into consideration when I guess the dose, but that doesn't mean that I'm not going to have to change it. So with Adderall, for most people, 20 milligrams XR is the best dose. And I just plain start everyone for the most part at 20. I know a lot of people might go with 10 first and then go up to 20. Um, I usually just go straight to 20. If I feel like this patient might be a little more sensitive, if I'm getting that feeling, and that might be like how they've responded to other medications, or how nervous they are about medication, or how they've responded to stimulants in the past, or other similar meds, or just meds in general. Or maybe they are a smaller female, and I think that maybe they won't need as high of a dose. I'll go ahead and say, here's 10. Try that for a week. If you feel like it wasn't enough, go up to 20, and then I'll see you back and see what dose you're on, and which dose you liked best. And if it's a Goldilocks and Three Bears kind of thing, like, oh, the 10 didn't do anything and the 20 was too much, hey, 15 right there, we nailed it. Let's try 15, see what happens. So like I said, with Adderall XR, I give most people 20 to start, and I'm talking about adults. But there are some people I'll start with 10 and go up to 20. I try to keep most people at 20. The max dose used to be 60. They've moved it down to 40. I think it's 60 for narcolepsy. Um, I'll have a few patients on 30. Oftentimes that 30 is like an additional 10 later. I do have a few patients on 40, but like for the vast majority, I find 20 is just that's the dose for adults. That is the dose I find the most useful for adults. With Concerta, I will typically start an adult at 36. You can go with 18. If I was going to go 10 with Adderall and then up to 20, that would be the same person that I would go with 18 and then up to 36. Um, sometimes I'll give them 18 and I'll say try 18, try 36, try 54, 72 is the max. I don't know. I have less problem going up higher on Concerta than I do with Adderall, because it's less addicting, less abusable, it's less strong. And honestly, I tend to see that patients need higher doses of Concerta. I much more often have patients on a 54 to 72 milligram dose of Concerta, whereas they're on, which it would be like on the high range, whereas I have them on a 20 of Adderall. So I will often, with Concerta, give them 18s, and I will say, go up one a week. I'll see you back in a month. With my ADHD patients, I often will see them back in 2 weeks. Um, and that's just because with a lot of our other meds, they take so long to work, but with ADHD meds, they don't. So if I have room in my schedule, I'll go ahead and see them back sooner, because I know I'm going to have the information I need sooner. And the sooner I can get them titrated and on their way and on the dose and the med that works for them, the better. So yeah, I tend to do 2 week follow-ups with ADHD versus 4 with depression, anxiety. If I'm treating something like bipolar schizophrenia, I'm probably going to see those folks back sooner, especially when in the early stages of managing it, just because those meds will also work faster, and also these are like patients that are higher risk. But my bread and butter patients, my depression, anxiety patients, I'll typically go a month as I'm titrating their doses, and then obviously less often once I've got them on the dose that was working well. But like I said, ADHD, I'll usually go a couple weeks. Um, but Concerta, I might give them 18s and say, go up 18, 36, 54, 72. And then I'll see you back and you tell me which dose worked for you. Sometimes I'll give them the 18s and I'll tell them to start with two of them. So start with 36 and then you can go up to 54 and 72. With Adderall, I tend to try to keep them at 20. Um, like I said, if I kind of think of Concerta is weaker, and so like if we go up to 72 of Concerta and it's just not enough, that's when I'm probably going to switch them to Adderall, and because I think that we'll be able to get there. Even like a 20 of Adderall is almost like a 54 or 72 of Concerta. So that's kind of how I dose, especially for adults. And like we're going to talk about the millions of different formulations of these drugs, but for the for the vast majority of patients, I'm using Concerta, Adderall XR, and sometimes I'll add some IR Adderall. Sometimes I'll add some IR methylphenidate if I need some extra boost. And then Vyvanse is another one that I use a lot as well. Um, those those are my bread and butter, and I'm honestly able to fix most people's issues with just those. What is that, like five? That's like five. So the two XRs and IRs of the two different meds, so that's four, and then Vyvanse, the fifth one. Pretty much all my patients are on that. There are patients I'd like to try on other stuff. I just didn't have them available. So I think, and if I treated kids, I would find a lot more use for the other formulations. But for adults, I'd say that those are good. I think something like My Deus or some of those other ones might be useful if I could access them. Right. So we will be talking about them all, but to me, I think the vast majority of your patients, those are, you could get away with just those right there, especially if we're talking about adults. All right. So going back to dosing, um, teachers are typically a better judge of child symptoms than the parents. Parents tend to think I feel like most parents tend to think their kids need more, but some parents don't think their kids need much at all, and the teachers are like, this kid is out of control, they need something. And then in other cases, like, I can't handle my kid in the house, do something about it, and the teacher's like, nope, they do great at school. And so sometimes that's a case of school being a more structured environment, and just kind of socially, like, the kid is like less likely to act crazy in a school environment where they're around other people that are not as familiar as they are at home. And then there's also the case of this stuff wears off, and so by the time they get home, they may not have much drug left in their system. And so the teacher's seeing them on drug and parents are seeing them off, in addition to the kids just generally going to behave better at school than at home. Not always, but like that's also a factor. So I would tend to favor what the teacher is saying a little bit higher than the parent, because that's when the kid really needs to be focusing the most. I know they're a pain in the butt for the parents in the house, and sometimes this might be a time where we need to like use Intuniv, but we really don't want it to last too long and affect their sleep and over medicate them and stuff like that. So we want them like focusing well at school and doing well at school, and that's like that's probably priority number one. If they're doing risky, horrible things when they're out of class, then that's when we are more concerned. But if the parents just like, I'm having a hard time managing them, that's a little bit less of a thing. And the thing is, what is it? Perfection is the enemy of good enough, right? I mean, if we can make things better, we've had a success. All right, so here's another thing: a child's treatment failure is often due to a failure to treat the parent's ADHD. So think about that. So sometimes the parent has uncontrolled ADHD, and that is the reason why they're having a hard time managing the kid. And then the kid needs better parental structure, but they're lacking it because the parent has ADHD that's not being treated. So I'll see this quite often, especially as an adult psychiatrist. Parents have no idea they have ADHD. They're they come to realize their kid does and see how well the kid does on treatment, and then they start to reflect, holy crap, that was me. I was exactly like this. um, Maybe I need this treatment too, right? Or they don't notice it and you notice it and you're like, man, this parent is all over the freaking place and the kid is doing great, but like the kid's probably like having some trouble because the adult's untreated. And so like if you're on the child side of things, you might suggest to the adult, hey, you might want to consider, getting treatment as well. Like that's not going to be for me because that's not what I do. And I don't know, maybe it is. Maybe you would be willing to do something like that for the parent, but maybe, you exclusively see kids. So like you're like, hey, maybe you should see your own doctor and ask about this. And then I'm on that receiving end of the parent that comes and says, hey, they said I should see you about this. So take that into consideration that it runs in families, and sometimes the kids' issues are caused by an untreated parent. All right. So a little bit more on dosing. All right. So um, when you're prescribing initially, have the patient increase the medication per the dosing schedule so the patient can get to adequate dose more quickly before next visit. I already described that. Often patients need one dose increase after a few months on a stable dose. So sometimes patients are doing well, and then after a few months, it's like, hey, this isn't working anymore. That's super common. I don't think of that as like them gaming me for more meds. I think of that as like it often takes a while for them to get used to something. And so I need to then increase that dose after a few months. And most of the time I don't, but like that is something like sometimes I'll have them on the 20 Adderall. They come back a few months later and they're like, it's not working. I'm like, all right, well, let's go up to 30 then. And then here's one thing. If they go on a long drug holiday, they shouldn't restart at the higher dose, right? So if they did well at like a dose and then we needed to up the dose, but then they stopped taking it for a long period of time, I'd go back to the dose that worked initially and wait till we need to increase it again. Because if they go straight to that dose, it's probably going to be too strong, which is another reason to like start with the 10 of Adderall and go up to 20. So for some people, if they start that 20, it's just like way too intense for a few days. Um, and that can affect their ability to want to take the med. So it can't hurt to like do the 10 first. So the FDA approved dosing. Here's another thing. So, and I'm a little skeptical of this. I got this from the Attitude podcast, ADD, Etude. Um, they seem to be a little bit overzealous. I think everyone on that podcast has ADHD and admits to it and talks about it. And so like and also I think they make a lot of money off of treating ADHD. So I'm a little bit hesitant to believe everything they say. I think there's a grain of truth. I think there's probably a pretty large grain of truth there, but I think they stretch things a little bit too much. So according to them, the FDA approved dosing range covers 50% of patients. So they're saying that 6 to 8% of patients may need doses lower than the lowest dose. So it may be like, hey, the starting dose is 10, but they actually only need 5, right? And sometimes it's hard to dose lower, right? So if you get someone who like appears to be dosed too high, um, some things you can cut, split, sprinkle less. There's liquids that you can dose lower. Um, some can be dissolved in water, even including long-acting Vyvanse. So some of the long-actings can be dissolved and crushed and sprinkled. When we go through each individual med, I'll tell you which one you can split and which ones you can't. Um, all the short-acting you pretty much can. Some of the long-acting you can, some you can't. And some of them you can't crush them, but you can sprinkle them. So we'll go into all that stuff. And then they're saying that 40% of patients may need doses higher than the highest dose. I think that's, in my experience, no way it's 40%. Because I mean, the highest dose is pretty high. I could see some patients needing more than 70 per 2 milligrams of Concerta, but I mean, more than 40 of Adderall, maybe I've given a couple patients 60, and 60 still sort of is in the dosing range. I would never give anyone more than 60. Um, maybe there, if I treated nothing but this, I would see that patient. I've seen patients on 90 and 120, and I've seen patients that have taken that in the past, and it just they seem like they were overdosed to me. That's what it seemed like to me. So I don't think they need that much. I think some patients like it, and then they will keep asking for more and more and more and acting like they need more and more and more. But like, I don't know that they necessarily do. Now that doesn't, so 40%, that's way too high. Maybe I'd go with the whole 6 to 8% again, for those. All right. So next point, patients may need different doses at different stages of life or with different demands. So if they have less responsibility, they might not need as much. Like a kid on a summer break, they may not need it all. They may not need it every day. They may not need as strong of a dose, right? Um, and if they're having late night class or late work, they may need a little bit more. So sometimes I give them the XR, and then I'll add some IR that they can take, but they don't necessarily have to take that IR after, like in the afternoon, um, every day, but just the days that they have that later need. If the patients are feeling stimulated or different or like a zombie, that's a sign that the dose is too high. So if they're kind of like jittery and like, out of it and stuff like that, that's when you might want to say, let's try a lower dose. All right. And so the right dose is the lowest dose that gives optimal performance without adverse effects. All right. Tolerance to adverse effects is much greater than tolerance to beneficial effects. And typically, dose will not need to be increased past the age of 16. That was from Attitude. So that sounds conservative. I like that point. So basically, what they're saying is if you find that perfect dose by 16, they're probably not going to need a higher dose than that if we've kind of settled into the right dose by that age. Um, and then this is something I do. This is controversial, the whole drug holiday thing. A lot of people say don't do it. I think I'm going to have more on this later, but like my opinion is, especially in adults, I noticed that they tend to, a lot of adults tend to have less effect each day they take the meds. So I'll often tell them to take the weekends off. That allows them to kind of like get the dose, the levels down to where it's going to work better starting the next day. And so I'll often say, take 2 to 3 days off, because if they're coming back and saying like it's not working anymore, it's not working anymore, and like this is a big problem, it's like, why don't you not take it for a while and then start it up again, and then don't take it every day, because I can't give you ridiculously high doses. And so the best thing to do is, what days do you need it the most? Take it on those days, and then take some days off of it. Now, in some cases, you can give them a higher dose. In some cases, you can't give them a higher dose for a variety of different reasons. Could be side effects, could be we're just like maxed out. And then a lot of folks do fine not taking it on the weekend, like they just need it for work or school. Some people are scattered constantly, and there are a risk in the car, accidents, that there are risks of like leaving the burners on. Those are folks that need to take it every day. So like you have to take all these kind of factors into consideration. All right. Something else with dosing. Let's talk about the effects that acidity has on amphetamine excretion. All right. So antacids, right? These like fight against acidity. Antacids may decrease excretion, leading to increased levels. And acidification, as with high doses of vitamin C, may increase excretion, decreasing levels. Okay, so if they're on antacids, like for GERD, heartburn type of symptoms, that could actually increase your levels of amphetamines. And then if you have something that's acid like that could be in your diet, or that could be an orange, right? It could be like vitamin C supplements they're taking, that can actually lower their levels. And we can actually use this one to our advantage, right? So you might say, don't take those together, or like you don't really need that vitamin supplement, to be honest. No, there's almost never a need to take a vitamin C supplement. Um, people get plenty of vitamin C. Like, I think it might be good to rub vitamin C on your skin, but like taking it orally, there's just not a lot of benefit to it, because most people get plenty or should be able to. So if they're having an issue where it's working great, but like the effects is just lasting too long, you could use this vitamin C to your advantage. Take 1,000 milligrams of vitamin C before bedtime, and help decrease the levels of that amphetamine. It takes about 20 minutes, and that might actually help them sleep. So that, that's a point that I think most of you probably have never heard before. You're like, oh man, this med works great, but it's like causing sleep. And if I lower the dose, it, doesn't work. And if I give them a shorter acting one, it doesn't last long enough. Hey, why don't you try the vitamin C trick? See if that works. This is what I'm saying, that like these meds are so fun to fine tune. They're fun to fine tune, right? That doesn't that sound fun, giving someone vitamin C to help them sleep? I mean, it sounds bizarre, and it's like something you probably never heard of, but it's really cool. All right. So even though amphetamines are the most affected by this, methylphenidate can be affected as well, um, but it's mostly just amphetamine. It's the most likely with the short-acting amphetamines, um, but there's virtually no effect with Vyvanse and Daytrona. And the reason why is because these drugs are not activated in our GI system, so they're not exposed to the acid, right? So Vyvanse is connected to lysine, and it gets completely absorbed in this state into your blood. So in that state, it can't be affected by antacids or acids. And so it then when it's in the blood, the there's an enzyme on red blood cells that cleave off the lysine, and they slowly activate the Vyvanse. So it basically bypasses this problem. So that's another thing. If you're worried about this problem, give them some Vyvanse. In my opinion, I like Vyvanse better. I would probably go with Vyvanse over Adderall. There's a couple issues with that. One, it might cost more. Insurance companies might want you to have tried Adderall first. Um, and another thing that really irritates me, the equivalent doses of Vyvanse to Adderall can be a little bit difficult to calculate. And the max dose of Adderall is like not near the max dose of max dose of Vyvanse. So 25 milligrams of Vyvanse is equal to about um, 10 milligrams of Adderall. So that means 50 is equal to 20. And that means that 75 is equal to 30, but the max dose is 70. And I've had pharmacies just like tell me there's no way they're giving them more than 70. And I'm like, well, that's like equivalent to like 27 milligrams of Adderall. So if you want to give someone 30 to 40 milligrams of Adderall, you really can't give them Vyvanse. So that's an issue you might have with Vyvanse, but I find that people tolerate Vyvanse better. And then Daytrona, that's the skin patch. So that's being absorbed directly. It's not going through the GI system. So we also don't worry about Daytrona when it comes to this acidity problem. All right. And what are some foods that we might be concerned about? So fruit juice, coffee, these are all the acidic things, right? Fruit juice, coffee, carbonated beverages, energy drinks, sport drinks, and vitamin C supplements. And then also keep an eye on the fact that vitamin C might be in other things. It might be in freaking cereals. It might be in like processed foods. It might be in a multivitamin. So that vitamin C might be sneaking its way in. All right. Let's talk about duration of action. All right. So we have all these different durations of action. We've got short acting, medium acting, long acting, ultra long acting. I mean, there's about 4 ranges. You've got like kind of a 4 hour, maybe like a 2 to 4 hour range, a 4 to 6, 6 to 8, 8 to 12, even like a 12 to 16. And there's different meds that have all those different ranges of action. All right. So when you're trying to figure out which one to do, it's like, first, which one do you start with? Because then you can kind of like see how the patient responds and then change it from there to go either shorter or longer, depending on how they reacted, right? And then, like I said, with something like My Day Is, by the way, you could just I just combine the XR, IR, save a bunch of money, and it's virtually works the same. So like you can also get around these branded products. And it's like, well, someone wants to take, I'm like, do you want to take 1 pill a day so that you can like have it cost like way more money? Is it worth that much more to not take an extra pill a day? Probably not. All right. So with the short acting ones, it used to only have short acting. You had famously Ritalin. That's what everyone knows it. That's the brand name. No one calls it that anymore except for the public. Ritalin is pretty much not used. It's branded methylphenidate, IR. Um, and then you've got like Ritalin SR, Ritalin LA. So those are like short, sustained release, long acting. Sustained release is a little bit longer. Long acting is a little bit longer than that. Concerta is a little bit longer than that. Concerta would be methylphenidate oros. That's the generic name for that. Oros is like, I don't even. It's like oral disintegrating product or something. It's just the way the system works with the way the pill is with the little like chambers in there and how they pop open at different times, and that's what the Oros stands for. But that's the generic name. So, which one do we start with? So the short acting formulations are often used for kids under 6. So if you've got someone that's on the young side, um, even like 6 years old, under 6, a lighter 6 year old, you may want to start with the short acting, because they'll be maybe more sensitive, and you may want to just dose that once a day. You might dose it twice a day. But the issue is they're at school. I remember when I was in school, and they would always like call the hyper kid down to the nurse's office in the middle of the day, and like it was because they needed to get their second dose of meds because there were no long acting versions when I was going to school, right? And like that's kind of embarrassing and inconvenient, and it's like you have to send meds with the kid to school and make sure the nurse has the meds, and then they have to get called out every day, and like if they forget to go, and I don't know, nobody wants to do that. Nobody wants to be that kid. So better to just have one pill to take in the morning that will last the kid all day, and for the most part we've got that now. And so the short actings are used less. They're used like in these like I said, in these younger kids. Sometimes the short acting formulations might be used to figure out what the optimal dose is before we switch. So just so that we don't make something that lasts too long, give them the short acting, kind of feel it out. What's the timing of this? And then based on what the timing of how they take the short actings is, all the long actings kind of kick in at different times and in different ways. And you can use kind of like how they responded to the short actings to pick the appropriate long acting. All right. So in kids older than 6, the long acting preparation can be used initially, starting with the lowest dose and titrating up. And then, like I said, especially in adults, you can combine long acting within a late afternoon short acting. If the because oftentimes the long acting, which are supposed to be like 12 to 16 hours, actually only work like 5 or 6 hours for an adult. Like my patients, they'll take it at 7. Usually takes about an hour to kick in. They're at work 8, and they notice that like after lunch they feel like it's not there. And so like even though this was an XR product, it's wearing off. I've dosed a lot of adults XR twice a day. And I don't know. People might be thinking, "What the heck are you thinking?" No, totally. This is an adult. If it's gone by noon and then they take another XR, it's still going to be gone and they can still sleep. So sometimes I'll dose XR twice a day. Sometimes I'll dose XR twice a day and have them take the second XR dose before the first one wears off. Usually you want to do it before it wears off to give it time to kick in around the time it wears off. Sometimes you'll do a short acting with a long acting at the same time, because like sometimes you do them both in the morning, because for whatever reason they need a little bit of that short acting added onto it in the morning, and then it lasts long enough. Sometimes you'll add that that extra IR dose in the middle of the day with IR immediate release, the shorter acting. Sometimes you'll add it later in the day. Sometimes it's like a as needed PRN later in the day, depending on what their activities are. So once again, this is a way of kind of like, this is not something that you see in the prescribing guidelines. These are expert tips, right? Um, if they got, some driving work, homework completion stuff in the evening, they may need that extra IR dose. And, they may dose it one day at 3 p.m. and another day at 5 p.m., depending on like what their demands are, right? So um, that the thing is, I generally like to go with the long acting over the short acting, because the short acting gives more of a dopamine hit. It's more of a full on, full off, which is like riskier for like dependence. And it just also like gives more withdrawal symptoms, gives more like, it doesn't last as long. It's like more intense. And then like, do they get that second short acting dose fast enough? Or, Is it kind of like in and then out, and then they have to take another one, and then in, out, rather than like a smoother curve? So the extended release, I certainly favor, um, to give the full day coverage, and then I'll add the immediate release kind of at the time of day that makes sense with them on top of that if we need that. Okay. Um, let's see. So this is the other thing. So giving a higher, you could also, you might be thinking, well, rather than give, say, 20 milligrams XR Adderall twice a day, why not just give them 40, right? So the higher doses usually don't last a whole lot longer, but they increase adverse effects. So they might take the 40 and it's just like, whoa, this is too much, and then it still wears off. Whereas if we do the 20 twice a day, it's like, okay, this is what I need, but then it wears off and then I have another one. Okay. So if you give a higher dose, generally it will last a little bit longer, but it'll also be more intense. And some people will need that higher dose, and some people just need the longer, split twice a day. And that's why you have to play around a little bit, to get the best dose for the patient. All right. So finishing up, I'm just going to mention all the factors. So some of these I've already mentioned, some of them I've yet to mention. But like when you're trying to pick the right formulation of the stimulant, what is basically every single thing that you're going to be thinking about? And then when we go over all these, I'm going to tell you about each formulation, how what you can do with each of these points, right? So one, you're thinking about how long do I want it to last, right? Am I worried about homework, driving the evening, that sort of thing? How long do I need? So that's one factor. There are people that maybe only need a short acting once a day. Maybe they don't need, that situation arises as well, right? So you need to know how long do they need the dose to last. Another point, can they swallow pills? Some of these have to be swallowed, some do not. And so if they can't swallow pills and this can't be crushed or sprinkled, then that's not the one to give. All right. You also need to know the time of day when the target symptoms occur, right? Is this something we need in the morning, or is this something we need later, right? Like, we don't want them taking it in the morning if like they don't start class till noon, right? So you need to know what time of day that we need this working. And for some people, it's as often as possible. And for other people, it's not. And so that's something important to know. Like, is this mostly at this? And for some people, it might be like, well, I need more at this time of day because that's when I'm in school or whatever. But then when I'm home, I still need it, but I don't need quite as much in my system. And so you pick the formulation or combination formulation to kind of suit that, right? There also like the desire to avoid administration at school. Like, how much do we want to avoid giving that second dose at school? I think most people do want to avoid that, but for some people that might not be an issue. Say they're homeschooled, right? So that might not be an issue, and it might actually work better for them to have 2 doses a day, because maybe it's flexible. Maybe we don't need 2 doses every day. We only need one some days, and then we're getting less drug into the kid, and and because they're at home and they're not at school, we're less worried about something like that. Okay, so it's important to you. This is why in psychiatry you always want to know their social situation, right? Like, what is their day like? How does their day go? What activities do they do? What are their social activities? What are their school activities? What are their work activities? What do they like to do? When do they do it? When do they sleep? When do they go to bed? When do they wake up? All these things are important to try and figure out how to target their symptoms the best. And with ADHD meds, because they work so immediately and wear off so fast, it's even more important. All right. Some other important factors. Do they have a coexisting tic disorder? So you may want to avoid stimulants and use an alpha 2 agonist in this situation, because stimulants could make tics worse. In fact, stimulants can cause tics in people that don't have tic disorders. That doesn't mean that we don't want to try it necessarily, but it may be a reason to avoid it, right? So do they have coexisting emotional or behavioral conditions like oppositional defiant disorder, that kind of stuff? So do we want to give them an alpha 2 agonist instead or in addition to, right? So that would be useful for the over aroused, easily frustrated, highly active or aggressive. So like more of the hyperactive symptoms, the intuitive could be useful, right? And sometimes we want to use both. Sometimes we only want to use one of them. Um, Another factor to take into consideration are the potential adverse effects. Is this somebody that we're having weight concerns with? Or this is already a skinny kid and they're losing even more weight on this? I'm going to have a whole thing on how to deal with weight. So I'm not going to go into detail now, but it's something to think about. Is this something where weight's become a concern on this med? Has blood pressure been a concern on this med? So like we need to react to that and give the appropriate meds so that we don't worsen these issues. Okay, is this somebody with a history of substance abuse? Do, and sometimes if they have a history of substance abuse, it's actually helping them to give them this med because they were self-medicating. In other cases, maybe they're selling their meds to someone else, or they're abusing the meds we're giving them, or a family member in the house is stealing them from them. Okay, so we might want to consider avoiding stimulants or using stimulants with less potential for abuse, like Vyvanse or Concerta or Daytrana. Okay, and then of course another factor is the preference of the patient and his or her guardian or parent, right? What do they prefer? What do they think will work best for them? Got to take that into consideration. And then we've got to consider the expense and formulary, right? Is this something that they can even get? Is this on the formulary? Is this something that their insurance will cover? Is this something that if the insurance won't cover, they're willing to pay for? Or is it something where we need to make sure, is this, even if it is the copay higher? And so, that you've got a variety of different costs here. So I'm going to tell you which of these drugs are generic and which ones aren't, right? So when we go through these meds, I'm going to tell you all the different durations of action, whether they can be swallowed, whether they have to be swallowed or not, how long, do they worsen, certain adverse effects? Are they more abusable? Are they more expensive? Are they less available? All these sort of factors. And so to me, that list I just gave you, that's everything you have to keep in mind for the most part when you're trying to pick which med is going to work the best for that patient. And it's a lot to balance. And I think it's cool. It's like a puzzle. I actually had a puzzle like this recently where it's like the kids overseas, they have limited ability to get certain meds. There's maybe ones that I would prefer for them, but those are less available. They're 6 years old, so, on the younger side. So like, do I go with IR? Do I go with XR? I prefer methylphenidate, but there's less methylphenidate that we're able to, swallow. There's less long-acting methylphenidate formulations that you can swallow. Can this kid swallow or not? And so, and then just the fact that they're in an overseas base, like the pharmacy just doesn't carry it at all. You can't even get things like Quillavant, Quilichu, and Mydeus and Edzaris and all these other crazy things, right? And so it sounds like a simple, straightforward case, but like their unique situation of like their age and their weight and their availability of getting products and their ability to swallow pills and all this stuff, you kind of have to go through the whole puzzle and look what meds fit with that situation the most. And here's the other thing, that med may not work for them, and then you've got to pick another one. Okay, and that's where this is cool, and that's where I think you're going to learn a lot about these ADHD meds. And like I said, this isn't really taught in residency very much. It's talked about, but like the detail that I'm going to give you, I'm going to give you very detailed instructions on like how each of these meds work, how their pharmacokinetics work in the body, like when it's really cool, and it's going to help you understand all of them better and know which ones work the best in the situation that you're dealing with right now. All right, so thanks for joining me today. I hope you enjoyed the show. I hope you learned a lot and that you're really excited to like, you've learned about all the factors and you're wondering like, well, what do all these meds do? That's what we're going to start getting into with our subsequent episodes on ADHD. So just to finish off and let you know the song I chose for today. Having a little trouble with these ADHD episodes trying to pick something that fits, but what I went with was the song "Process" by Less Than Jake from an early album of theirs, Pezcore. I actually did a Less Than Jake song from Pezcore for the last episode. I did Black Coffee. This time, to me, I'm talking about the algorithm of how to select a med, and so to me, Process is kind of like an algorithm. So that's why I picked this song. I hope you enjoy the song. I encourage you to, download these for real and pay for them and get the whole version. And tune into our next episode. I'll see you next time.